Models for Ethical Medicine in a Revolutionary Age, Robert M. Veatch. The articles in Chapter 4 are all dealing with very specific questions about how professionals ought to behave in relation to the people that they're working with. In Robert Veatch's article, what he's attempting to do is give an account of how doctors ought to interact with their patients. So what is the proper way to conceive of the doctor-patient relationship? What Veatch essentially does is take 4 models that have been prevalent in the health profession and show why most of those, aside from the last, the contractual model, fail to be morally good models for the relationship between doctors and patients. So he offers 4. There's the engineering model, the Priestley model, the collegial model, and the one that he will ultimately endorse, the contractual model. The engineering model. The first model Veatch considers is the engineering model. According to the engineering model, the obligation of the doctor is to provide the patient with all the relevant information, for the patient to select the medical intervention, and for the physician to execute the selected intervention. Essentially, the engineering model holds that doctors are simply to give the patient the information necessary to make the medical decision, but not actually make the decision themselves. So, for instance, if you went to a doctor complaining of some pain in your knee, the doctor's job, according to this model, would simply be to diagnose the problem, give you the treatment options that you have, and then simply wait for you to make the decision as to which option you want to take. On this account, the doctor is to remain objective. So he or she must be factual in divorcing himself or herself from all consideration of value. So in other words, the doctor isn't to impose their personal beliefs about the course of treatment. A doctor may say, look, here's treatment 1 that you can use for your knee. It has a success rate of X%. Here's treatment 2. It has a success rate of X%. Here's the pros to treatment 1. Here's the cons to treatment 1. Here's the pros to treatment 2 and the cons to treatment 2. And now it's time for you to make a decision. Problems with the engineering model. According to Veatch, the engineering model is an inappropriate model of the physician-patient relationship. To begin with, it promotes specialization and impersonalization within the medical profession. What Veatch sees as a default or a defect here is the idea that a physician would be so specialized and so impersonal that they would miss out on the patient as a whole. So when they're specialized in, say, knees, and when they're to be completely impersonal in the matter, they don't get to know the patient's needs, the patient's lifestyle, the patient's sort of values. And in doing so, they seem to miss an integral part of what makes for a good treatment. Different treatments have different pros and cons, and those are going to depend in part upon what sort of life you lead. If you're a professional athlete, for instance, certain treatments are going to be better if you're going to be, say, abusing your knees more in your work, as opposed to the person who likes to do the occasional jog or take a bike ride, who isn't reliant on their body for their well-being, that is, how they make money. Another problem with the engineering model is the false assumption of a distinct demarcation between facts and values. Although it may seem to be the case that doctors can remain value neutral, in other words, simply giving treatment options and the pros and cons, what Veatch says is that most physicians don't do that, or subconsciously may actually push one form of treatment over another. So to pretend that there's actually a completely objective point of view is false. This assumption, says Veatch, says in most cases doctors are going to put forth the treatments they think are best, even though they may hide behind this sort of engineering model. Another problem is that this model incorrectly presupposes that patients have known and fixed values. There's no room for self-reflection and deliberation about values. Now, what we mean by values here are the things that an individual may value in their life. Treatment options may mean taking a look at what it is you value not only now, but what you're going to come to value in the future. So, for instance, a personal case. I once had knee surgery. I had knee surgery for an injury suffered while doing martial arts. When I went for treatment, the doctor gave me two options as to how they could treat the knee injury. One way was to shave the cartilage that had been damaged in the knee, actually shaving off a part of it, and then stitching up. And the other one was to sew the cartilage back together. Now, if they just simply given me the options and had me make my decision, I probably wouldn't have made a value decision. The physician that I had at the time actually said, what sorts of things do you anticipate doing not only now, but in the future? How long do you want to be in a cast? What do you think your life is, where your life is going to lead you? Are you going to be doing this professionally as a martial arts instructor, or is this something you do as a hobby? And so forth. And once those values, not only now, the values I have now, but what I might have in the future, what things I was doing with my life at the time, and what I anticipated doing, all of those things go into a medical decision. Now, maybe something like a knee surgery, when it's arthroscopic, fairly minor, isn't something that needs a lot of self-reflection. But other decisions can, in fact, require a lot. For instance, cancer treatments, long-term versus short-term, quality of life versus quantity of life. And the engineering model seems to ignore this idea that people may not be completely self-reflective, may not know about these things, and it may be the physician's job to help them sort of tease out the implications of various treatments given their own personal set of values. Finally, there's the physician as plumber model, and Veatch says that we can sum up actually these first 3 points as just that. Plumber comes in, you say, I'd like to get water to this bathroom, I want to install a shower here. Physician comes in, lays down the pipe, and they're done. Without any questions about whether it's a good idea to put this in, whether you need this bathroom, blah, 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 all of those sorts of things. And so Veatch said there seems to be something missing here when we completely rule out values and we can completely rule out that sort of personal side of medicine. There's something missing in this type of model. The Priestley model. The next model that Veatch considers is what he terms the Priestley model. The Priestley model can be thought of sort of at the other extreme, or the other end of the spectrum as far as models of the physician-patient relationship go. So we can imagine a line in which we have two endpoints. On one end, you would have an engineering model, which is completely impersonal, and on the other extreme, you have the Priestley model, which is extremely personal. Under the Priestley model, physicians' ethical judgments are an essential aspect of the physician-patient relationship. So notice in the previous model, Veatch had noted that the engineering model says the physician's ethical judgments are completely irrelevant and should be kept completely out of the decision making. On the Priestley model, we want the physician's input. So as I'm mentioning in the model, when I had my own knee surgery, the physician asked me about values, talking about what would be in my best interest and things like that. This is what sort of the Priestley model has. The Priestley model also has as its fundamental moral principle the idea of benefit and do no harm, what we call beneficence and non-malfeasance. Do good for the patient, but don't harm the patient. Now, under the Priestley model, rather than conceiving of it as a dialogue, the physician's responsibility is to make the best judgment for the patient. So the patient's interests are secondary in some sense to what the physician thinks is the best course of action. As it says here, it takes the locus of decision-making away from the patient and places it in the hands of the professional. So under the Priestley model, which it has, quite frankly, fallen out of favor, it would be the case you'd go in to see a physician, they would diagnose the problem, and then they would tell you what course of treatment. So it wouldn't be treatment options. If there was more than one, it would be the physician's responsibility to decide which treatment option was best given your situation. Problems with the Priestley model. The first problem that Veatch notes with the Priestley model is the speaking as a syndrome. Now, essentially what Veatch is talking about with this objection to the Priestley model is the idea that when a physician says, speaking as a physician, you ought to do X, or speaking as a physician, you ought not to do Y. What they seem to be doing is switching expertise. When I'm speaking as a physician, that implies medical expertise. But the speaking as a syndrome normally indicates that we've made a transition to a moral claim. So the Priestley model, in this way, when physicians speak as a physician, they're really exchanging expertise. if I say you shouldn't do this treatment, speaking as a physician, I would not recommend this treatment for you. What they're really saying, or we might ask, why aren't they really saying, as a moral person, as a good person, do this, or I wouldn't do that? And they seem to cloud it. It seems to be a way of mixing, conflating the expertise in medicine with a moral expertise. The second sort of problem is the parent-child image of the physician-patient relationship. The Priestley model is essentially a paternalistic model in which the physician acts as the parent and the patient as the child. So rather than the patient having an active role in their treatment, under this model, they're simply to listen to the orders given to them, much like a child would have to listen to the parents. Eat your broccoli, take your vitamins, whatever it happens to be. And so Veatch finds this objectionable because patients, unless they actually are children, ought not to be treated like children. We think it's okay to be paternalistic in cases where the person is unable to act in a mature, autonomous manner. So we don't have any problem with parents being paternalistic towards children. There's nothing offensive about that. But when one adult acts paternalistically towards another, when they attempt to do what's in that person's best interest, regardless of what that adult person wants, then we think that there's something morally offensive about that. And finally, the last problem that Veatch notes with this Priestley model is the idea that it minimizes other morally relevant principles found in a balanced system of ethics. We'll talk about these a little more in the next slide, but what it essentially says is that there are really only two fundamental moral principles. That is, to benefit and do no harm. So things like autonomy, the ability to make a decision for oneself, is completely thrown out under the Priestley model, or at least it's thrown out to a certain degree. And in such cases, what Veatch wants to say is that a model like this ignores other morally relevant principles, other things that we do in fact value. And we'll talk about some of these on the next slide. Moral norms. As was previously mentioned, the Priestley model seems to ignore a number of moral norms we find important in an individual's life. So we mentioned beneficence, to do or produce good, and non-malfeasance, which the Priestley model does actually encompass. But what it ignores are the following: individual freedom, which is essential to being truly human. To be a free and rational agent, you need freedom, the ability to make choices, to make decisions about how your life wants to go. The preservation of individual dignity, so the maintenance of freedom of choice and control over one's life and body. So when we talk about individual freedom, individual dignity, these things seem to be ignored, since at no time is the individual really important in the decisions made under the Priestley model. Truth-telling and promise-keeping are two things that we often view as morally important. Ignoring these can pose a threat to trust and confidence in the physician-patient relationship. So under the Priestley model, I'm not actually required as a physician to tell you the truth if I think that truth may harm you. So for many years, and even up till today, in Italy, for instance, the value of truth-telling is often given a back seat when it comes to keeping someone's spirits up. So traditionally in Italian medicine, what would happen is that if someone came to a doctor in Italy and the doctor discovered that this patient was suffering from a terminal disease, rather than telling that patient the truth, which the doctor would say could only cause them stress and fear and harm, in essence, the physician would call in the patient's family and tell them what was going on and to make this patient as comfortable as possible. But to the patient, they would simply tell them, for instance, to take it easy and that they should perhaps rest and not overexert themselves and so forth. So in instances where some sort of treatment wouldn't help in whatever this terminal illness is, under the Italian system, truth-telling would take a back seat. Now, most of us, I think, expect from our physicians that they're telling us the truth, that regardless of whether this may cause us some sort of psychological harm, that we want to know that our physician is telling us the truth. And in fact, if we knew that our physician could keep things from us, this would obviously undermine our trust or confidence in the physician-patient relationship. And given that this is something that's ignored under the Priestley model, Veatch finds, again, a problem with this approach to the doctor-patient relationship. Finally, there's the idea of maintaining and restoring justice. There must be an insistence on a fair distribution of healthcare resources. So again, in justice considerations and distribution of healthcare, if I believe my physician is acting in a way to make his or her own decisions about justice, especially about just distributions of healthcare, it might be the case that the physician would say, well, given a patient's advanced age and so forth, certain treatment options shouldn't be prescribed. Well, this I think we would find morally offensive in some way, because that would be making a justice call, or would be ignoring perhaps my just claim to treatment. So the physician may disagree with this because their job is to benefit and not to harm, but there may be a justice question here, that a fair distribution requires that I get a treatment if I want it. The collegial model. Considering the problems with the previous two models, Veatch offers a compromise between the two, known as the collegial model. In the collegial model, the physician and patients are pursuing a common goal of eliminating illness and preserving health. So rather than view the doctor as a completely objective sort of information source, or viewing the doctor as someone making all the decisions, Veatch says the collegial model offers sort of this middle ground where the physician and patient work together as colleagues trying to fight disease. So it's based on the notion of trust and confidence between physician and patient, the two working together for a common cause, giving equality of dignity and respect, and valuing the contributions each makes to the healthcare situation. So it seems to be the case that the collegial model makes up for the shortcomings of the previous two models. There's respect for the patient. There are these other sorts of moral norms that we are encouraged to abide by. And in this model, those things are respected. At the same time, the physician doesn't abrogate all responsibility for decision making. The physician would have an active role, giving some of their input on, and their values would be part of the medical decision making. Problems with the collegial model. Just as with the previous two models, Veatch finds a difficulty even with the seemingly good collegial model. His first problem with this model is the question, is it realistic to believe that mutual loyalty and common goals exist in the physician-patient relationship? In other words, can we really believe that physicians are loyal to their patients and patients to their physicians? Is this a realistic sort of relationship that goes on in the medical profession? Now, it may be the case that many people have physicians who they've been with for many, many years and know them fairly well. On the other hand, with HMOs and with people moving around quite frequently, and especially in cases with younger individuals, very often you don't have a physician that you've known for several years. You may, while growing up, have one doctor that you went to and know fairly well, but by the time you're an adult and you're off your parents' insurance, as you're looking for your own physician, you may only see that person once every 6 months, once a year. Perhaps you have to go once or twice for a checkup, or if you happen to get sick. But on the whole, we don't normally have the sort of relationship with our doctors that we might see in the movies as old doc so-and-so that we see all the time down at the diner or something along those lines. So it might be unrealistic to think that a collegial model, where there's supposed to be this relationship between physician and patient, actually exists today, given the way medicine is practiced. The other problem with the collegial model deals with ethnic, class, and economic differences. When we're talking about individuals who are colleagues, normally we have individuals who have similar sorts of background or similar sorts of training. But that's not always the case. In fact, it's very rarely the case that we have the same ethnic, class, or economic status as our physician. Normally, physicians do very well. So for the most of us, we find that our physicians are probably of an different economic class. Many times, physicians come from more privileged backgrounds. Not always the case by any means, but that may be the case. Ethnic backgrounds also abound. Physicians coming from not only within our society, but the number of physicians that come from other countries, from India or China or Japan. You might find a number of different types of physicians with different ethnic backgrounds, which makes this notion of a colleague or collegial model difficult because we don't have the same frame of reference that our physician does. And so this brings us to the third point, which in a sense summarizes the previous two. Is there any real sense in which physician and patient are equal? So we've already talked about the fact that we're not colleagues working together in the same way because we oftentimes don't see our physician on a regular basis. We're oftentimes have differences as far as ethnicity, class, and economics go. And then, of course, the very obvious inequality between physician and patient. That being that the physician has the training as a physician and we don't. When we talk about colleagues, we normally talk about equals, people working in the same field. If I talk about my colleague in the philosophy department, what I'm saying is that I have a similar sort of training as they do. I can talk the same language. I have the same or similar background. There may be varying degrees of experience, but there's still enough of an equality that we all sort of know the same sort of basic background information. And that's not actually the case with the physician and patient. And so it seems an unrealistic model, even though it might be an attractive model. It seems extremely unrealistic that this one would work for us as a model of how physicians and patients ought to interact with each other. The contractual model. So given the deficiencies in the previous three models, which model does Veatch advocate? Well, Veatch believes that what we need is a contractual model of the physician-patient relationship. Now, by a contractual model, he doesn't want to view this in overly legalistic terms. In other words, we shouldn't think of the contractual model as a very specific actual contract that individuals sign. Rather, he wants us to view it as a contract or covenant in the tradition of a marriage. In other words, there's some vagueness to the contract, but we know that, for instance, in a marriage, there's supposed to be fidelity, there's supposed to be trust and mutual support. There's the sort of idea of taking on financial obligations together and children and so forth. And all of these things are assumed in a marriage, that there'll be a sort of equal partnership in the things that come before the marriage, and that at times various strengths of one person will be drawn on where the other person doesn't have those strengths. And much the same way goes for the contractual model in the physician-patient relationship. So it maintains the basic norms of freedom, dignity, truth-telling, promise-keeping, and justice. In other words, those are presupposed under this model, that doctors and patients will work together, not collegially, because we understand these sort of differences, and we understand what sorts of things we'll have to defer to the physician on, and the physician also understands that they're not responsible for making all the decisions, that they have an obligation to maintain those norms, and in doing so allowing the patient to have an active role in the way in which they're treated. Now, the contractual model has actually come into favor. Anyone who's gone in for any sort of minor procedure, maybe even getting wisdom teeth pulled out at a dentist's office, will note all of the various things they'll tell you before they put you under, all the possible ramifications of this, what could happen. This could happen, this could happen, you could suffer from this, there could be blood clots, there could be this, to the point at which we almost are scared to have any procedure done. But that's part of this notion of a contractual model. I'm not keeping anything from you. I'm telling you the truth. I'm giving you as much information as I think necessary for you to make an intelligent decision about your health care, and I'm giving the recommendation to you as well. So obligations and expected benefits are understood by both parties. And in this sort of case, when the model is contractual, the physician can say, here's the sorts of things I'm obligated to do. The patient can say, here are the things that I'm willing to do and the decisions I want to make. And either party can withdraw from the relationship if they don't like the terms of the agreement. So it really, in that sense, is contractual. That you go in there with an understanding of what sorts of things you expect from the physician and what the physician expects from you. Advantages of the contractual model. According to Veatch, the contractual model has much to recommend it. To begin with, it avoids the abdication of responsibility found in the engineering model. If we remember back to the engineering model, under that relationship, the physician was not responsible for making any sorts of value judgments about courses of treatment. The physician's sole purpose was to give the patient options and then allow that patient to make those decisions. Under the contractual model, the mutual respect, dignity, truth-telling, promise-keeping, along with this notion of the contract or covenant in the form of a marriage, means that these things should be discussed. The physician should take an active role in helping the patient come to some sort of determination about their values in order to make that sort of responsible decision. Another advantage is that it avoids the moral abdication of the patient found in the Priestley model. So notice in the Priestley model, the individual isn't responsible at all for their health care. The patient is responsible or is required to simply follow the dictates of the physician, but it's not, the patient isn't responsible for making any of the moral decisions in this. Aren't required to bring in their own moral judgments or values. That's something to be left to the priest. And Veatch finds this problematic as well, because if we look back at those moral norms, individual freedom and individual dignity requires that we do in fact take some role in our medical decision making. Thirdly, it avoids the false sense of equality found in the collegial model. As we noted before, we're not actually equals in a relationship with our physician. If I was an equal with the physician, odds are I wouldn't need the physician, or at least I could interact with the physician in this collegial way. But the truth is we're not equals with our physicians, and so this false sense of equality doesn't help in actually making good decisions. So with the contractual model, there's a sharing in which the patient has legitimate grounds for trusting that once the basic value framework for medical decision making is established on the basis of the patient's own values, then if we go to page 91, then what we know is that once that groundwork has been established, then the patient is confident that the decisions made are good decisions in line with their values and respecting their dignity. So under this model, says Veatch, once we've established this groundwork, once there's this understanding of the obligations on both parties, then we can have good, solid moral decision making in the context of medical decision making.